Thank you very much, Mr. Chairman. I want to thank you and the ranking member for leading us through these last 2 years of this subcommittee. And I think it's fair to say that members on both sides of the aisle have had an opportunity to express themselves, but also an opportunity to listen to and to, at different points, appreciate the positions of other members of this committee that may not be in line with ours. I want to thank, in particular, the ranking member for leading us toward a minority report, which was, as we know, submitted and carried the best thinking, the thoughts, and the position of those of us on this side of the aisle, and just both of you for the way you've worked together and the example that you've put forward. I always talk about real time when I get a chance to speak here on this committee because COVID was real time. And there was no playbook, there were no real guidelines, and we learned and we made mistakes in real time. The one thing that I do want to preface all of my remarks with is that we must never, ever, ever forget the millions of people who died here and all over this globe as a result of this pandemic. We don't talk about them that much as we get further and further away, but we cannot do an autopsy of what we went through without mentioning the fact that so many lives, so many families were and still are affected by this. So we have a special calling, I think, to find in a bipartisan way those things that will help us in future years as we look back on this. And it is important in many respects, since we are no longer in real time of a disease, that we do that autopsy, do it the right way, and make sure that this Congress at least leaves behind at the conclusion of this select committee a path and a way forward and a number of suggestions and other things that will help us well into the future. Now, I think it's, for me at least, always important to make sure that there is a public record established, and sometimes it means through redundancy. So I want to speak directly to you, Dr. Walk, Dr. Tabak, maybe Dr. Marston, and be a little redundant here, but redundancy is important because if, in fact, in your positions, and if, in fact, with the expertise that you bear, that you say what you said prior to this meeting over the last several years, but that you say it one more time. So, Dr. Marston, Dr. Walk, give me, please, what you believe is the way that we can, in this nation, persuade the public that approved vaccines are safe and effective while taking into considerations the things that come up after the issuance of those vaccines that call attention to special groups or special circumstances that then ought to be rolled into how we move forward. Either or both of you, if you could.
Thank you for the question. Related to mistrust around vaccines, a federal agency like CDC can make recommendations for vaccines and with our other agencies create the scientific base to show that they are the best defense against hospitalizations and deaths. But I remember when I was the Emergency Operations Center in 2000 watching the deaths climb. And then when vaccines became available, I saw the rates go down, and it was tremendous. It was magnificent. But then the distrust and the miscommunication around vaccines started, and we saw those death rates plateau. A federal agency can only do so much. It requires healthcare providers in that relationship. It requires communities, leaders in the communities, and various different types of leaders, actually, to trusted leaders.
Well, and let me interrupt you here. I'm also trying to get to what happens when there are new developments after the issuance of a vaccine. The gentlewoman from Iowa spoke about the enlargement of the heart syndrome and how that was believed to be affecting certain groups. When those types of information come forward, how do you evolve then your presentation of the evidence or of the vaccine? Because if not, there's going to continue to be a great deal of mistrust.
I'll start. Again, we have these adverse event surveillance systems in place to detect any adverse event, and then we have other systems in place to try to see if there was a cause, if myocarditis was related or not. And once we have that type of information, we try to push that out in various ways, including in scientific publications, but also through, again, various state and local leaders to try to engage with those communities.
Is that what we did?
That is what we had a multi-pronged approach to try to communicate the risk related to vaccines. But again, I think there's a number of different communities in our country, and we need to do better, I believe, at trying to reach those communities to talk to them about what are some of the issues they have with vaccine.
Dr. Tabak,
if we can. Your time has expired, but I do want to let Dr. Marston reply as well. I think it was a very important question that you asked, and I'd like to give you the opportunity to reply.
Thank you, Mr. Chairman. I'd be glad to. So the truth of the matter is that we work quite closely with the CDC on these matters. And the most important lesson I think that we've learned is to show our work and explain our work. For example, when we see a safety signal in something like VAERS, we're going to look at our multiple systems to see if that actually is something that is plausibly related to the vaccine. We then have, in multiple cases, taken those analyses and put them into the published literature. We also present them at advisory committees. I think one of the things that we are also looking at is that that's not good enough, right? So that reaches a certain group of people, the people who are regularly reading the medical literature, for example. We need to take it a step further, right, and communicate those things on multiple levels so that they're easy to understand. So one of the things that we've been doing is working with the clinician community, trying to make sure that they're armed with digestible information that they can then relay to their patients, because people might not be listening to the federal government, the public health agencies. I hope that they will, but we also want to make sure that we're meeting people where they are, and if that's with their local clinician, with their physician, with their nurse, we want to give those people the info they need.
Thank you. Thank you for the extra time, Mr. Chairman.